We all have different insurance plans that are according to our work or to our or a very, very specific, class in life. It's whittled down to us, and we're trying to decide, how much we're trying to hedge. How much are we going to be spending in healthcare? How much coverage do we want? But I think that one of the lessons is that we gain a lot from community, and the way that a public healthcare system provides that is through looking at everybody and trying to address the needs and trying to take advantage of the people who are able to provide that care in the community.
Welcome, bienvenidos to the Lowell Humanities series. We're thrilled to kick off the fall semester with the first event in a tradition that dates back to 1957. Today's talk, The People's Hospital by Ricardo Nuila, is co-sponsored by the Park Street Corporation. Let me start with a personal note. I couldn't put this book down. It's the beginning of the academic year. I have, insane things to do like everybody at the beginning of the academic year, including a 14-year-old freaking out starting high school. And that book kept me up at night because I'm going to tell you why. Because this book does something that is both radical and counterintuitive in the American healthcare system. Radical because it treats every person as fully deserving of high-quality care. No insurance, no problem. No English, we'll speak your language. No documentation. You still receive the best care possible. Counterintuitive because it proves that this approach is not only humane, but efficient. A viable alternative to one of the most dysfunctional healthcare systems in the world. As a social work professor, deeply engaged with safety net clinics and hospitals serving mostly Latino immigrants, the People Hospital greatly resonates with my work. We have seen that culturally responsive care isn't a luxury, it's a necessity. Patients who receive care in their primary language are more likely to understand diagnosis, follow treatment plans, and report better health outcomes. The People's Hospital reflects this reality. Interpreters aren't an afterthought. They are integral to the care team. But language is only one piece. In another study, we found that access to universal, high-quality healthcare, like the one provided at Taub Hospital, increased immigrants' sense of deservingness and belonging. We have seen that when people feel seen, they show up, not only to appointments, but to their communities. They volunteer, they vote, they build lives. Deservingness is not a soft metric, it's a cornerstone of public health. The People's Hospital shows us what's possible when equity guides care, where social workers collaborate with doctors, where care teams ask about housing, food security, and trauma, not just symptoms. It's a model I've seen in my work. One of my graduates, for instance, redesigned intake procedures to include migration history and family separation. Another advocated for trauma-informed pediatric care, recognizing the invisible wounds children from immigrants' families often carry. These are not isolated efforts. They are part of a growing movement to make healthcare more humane, just, and effective. We need more hospitals like the People's Hospital, where care is people-centered, is rooted in cultural humility, and treats all patients as deserving of the highest quality of care. Because health is not only about medicine, it's about deservingness and belonging. About our speaker tonight. Dr. Ricardo Nuila is a writer, teacher, and practicing physician. He serves as an associate professor of medicine, medical ethics, and health policy at Baylor College of Medicine, where he directs the Humanities Expression and Arts Lab program. In addition to his clinical work at Taub Hospital, a safety net hospital in Houston, Dr. Nuila writes about health disparities, policy, and the human stories behind medicine. His work has appeared in The New Yorker, The New York Times, and The Atlantic. The People's Hospital is his acclaimed debut book, praised for its powerful storytelling and vision for a more equitable healthcare system. Please join me in welcoming Ricardo Nuila.
Thank you so much for that introduction, Rocio. That was a really beautiful introduction. I'm very happy to be here. Thank you all very much for coming tonight. It's truly an honor to be with you tonight. I have Jesuit education imprinted in me from high school through college, and so it's imperative. It's really just, when I received this invitation, I just thought that this was one of the most wonderful invitations that I've had because of that. Today, what I'd like to do is go through the story of healthcare, but also a hospital in Houston, the one where I work, where I found humanities, my study and love of the humanities and literature come together with social justice and really became a place where I found home, my second home. I'm only going to show you one slide today that has a graph. That's this one right here. Okay, I'm sorry. But the rest of it you'll see is actually art made of patients from Taub Hospital. And I'll be reading from parts of it, discussing some parts of it and how they relate to that nexus of the humanities and medicine that I found in the public hospital where I work in Houston. But this has, I think one of the reasons why I respond so emotionally to this is because of that Jesuit education. I think that this graph just shows how extreme we are here. This is a study published in the New England Journal of Medicine. I realize that I'm in a mecca here for healthcare and medical studies, and I'm very proud to be here for that. But this came out in 2024, just really showing how extreme healthcare, the system that is supposed to provide healthcare in America is, which is that we have healthcare spending on the x-axis all the way to the right, and the system performance is low. Now that system performance is based on multiple factors, including equity, access to care, but also quality of care. And you can see that the Jesuit education in me feels two things. Number one, it's not rational that we are paying so much for healthcare, and this creates inequities. This is the product of some people getting healthcare at very high prices and some people not getting it. So with that in mind, I want to introduce you to a place that I learned to call my second home, Taub Hospital, and I'm just going to start by reading from the very beginning of the book, so that we can embark on this journey about showing you a little bit about my where I work. The rumor we heard was that patients arrived with hand-drawn maps. Our hospital marked like treasure. The stately Nigerian lady who responded, "Yes, doctor," to everything, metastatic breast cancer. The boy with the black curly hair wearing red Converse All-Stars and a Judas Priest t-shirt that screamed Mexico City, acute lymphocytic leukemia. The grandmother with the sari snagged in the guardrails, chest pain, real chest pain, might need bypass. We stood at these patients' bedsides. We wrote down their histories. We said we were sorry for examining them with cold hands. We ordered blood tests, interpreted EKGs, scrolled through their CAT scans. We input diagnoses. We weren't just doctors. Among us were nurses, social workers, x-ray techs, the people who rode up and down the hallways in the middle of the night, waxing the floors. Some of us wore white coats with frayed sleeves and busted pockets, others tight-fitting scrubs embroidered with our names. In our bad moments, we became tribal. We weren't we We were ortho, medicine, plastics, the 4A nurses. We only covered the unit. More often, though, the needs of our patients were so damn immediate, we found a way to work as one. We ran blood transfusions, heparin drips, a morphine pump when Norco didn't touch the pain. When COVID came, we gave oxygen together, one of us twisting the knob on the valve while the other inserted those tiny prongs into flared nostrils. We consulted one another when things looked dicey, surgery if we found boils, ID for antibiotics. And if anything looked remotely like a seizure, a twitch, a rolling of the eyes, we paged neurology overhead. If transportation was swamped, we wheeled them ourselves to MRI, to special procedures, to the cath lab, even the ICU. How downtrodden we looked when we did this, like beaten dogs. We figured out ways to make things work. Not enough money for your meds? We Googled the $4 list at Walmart. Muscles too weak? We dug up a refurbished walker from the basement. Dying and homeless and alone? We called in a favor from the hospice that used to be a Tudor-style home. And when our work was done, once we could envision someone not dying within 24 hours of our discharge order, once the first chemo had gone in, once we could be sure their chief complaint was addressed, the thoughts still lingered in our minds. What brought them here? What are their stories? Ben Taub Hospital, the largest safety net hospital in one of America's most diverse cities. We are Heathrow if you replace the Emirates and the Virgin Atlantic planes with Greyhound buses. There are no atriums with pianists here playing Here Comes the Sun to welcome you. No soothing sounds of running water from hidden speakers or, gasp, from an actual indoor waterfall. There is no Starbucks. Our cafeteria serves some form of barbecue most days for lunch and packaged salads topped with egg or chicken strips. That's unless you prefer the full menu McDonald's located inside the hospital that's open 23 hours a day. We do have a gift shop, though it looks more like a convenience store, heavily stocked with greeting cards. Not the pun-filled ones, rather the kind that get the point across. Condolences, available in Spanish too. If you type Ben Taub into Google Maps, you'll find it crammed between the Houston Zoo and the 30 other institutions that make up the Texas Medical Center, the largest concentration of medical facilities in the world. Some of the field's most important innovations took place in this medical metropolis. The first successful bypass, the first artificial heart transplant, the first beatless artificial heart. Imagine that. No lub-dub, just a constant whirring. The first silicone breast implant, one of the first civilian helicopter ambulances, the Bubble Boy, all here. Not that the patients at Ben Taub know this. Some may have heard that MD Anderson is rated top in the country in cancer care, or that at Houston Methodist, you might find yourself fortunate enough to have a robot operate on your prostate. The TV ads air in Spanish too. It's possible that at night our patients look out their windows and behold the sparkle of so many new glass buildings, some of them named after billionaire sheiks who sell the oil that becomes their gas. More likely, they're looking out in the direction of the zoo, toward the parking garage and bus stop, wondering how they'll get home. So I grew up in Houston, and I grew up in a medical family, and I knew nothing about what the public hospital in Houston was. The only thing, Ben Taub would resonate with me because when we'd be driving with my father, when he'd be dropping us off at school, maybe he'd put on the AM radio and you'd hear there was an accident or there was a shooting, the victims had been taken to Ben Taub. And that's how I kind of understood what this place was. Ben Taub is just the place where other people go, where people who have accidents or people or something, when something bad happens, people go there. What I came to realize going to school and learning at Ben Taub, also working there, is that it's a place where people need to go sometimes, and sometimes people choose to go because of the way the American healthcare system is organized. Now, what I've realized is that the American healthcare system is such that all of us have ice beneath our feet. And then sometimes that ice, is too thin and people fall through. Some of us are very privileged enough to have thick ice underneath our feet, but I've seen some people who simply don't have enough ice, and then they fall through the cracks. And I want to introduce you to one of my patients, one of the people that this book examines the story of, and that's one of my patients named Stephen. If Stephen Hart was good at one thing, it was managing restaurants. For 12 years, he'd resurrected different branches of a burger chain in Houston and made them profitable. Stephen didn't have an MBA or any kind of special training. He had people skills, which, after some twists and turns in life, had bloomed for him in the service industry. The truth was that Stephen enjoyed going out of his way to help customers. He loved becoming the highlight of someone's day. That corporate talk about turning an ow into a wow sounded lame, yes, but in fact, it made him tick. He wasn't one of those general managers who buried himself in an office tracking avocado prices during the dinner rush. Rather, he preferred striking up conversations with customers the moment they stepped through the door. One night, while Stephen was taking orders at the counter, a guest mused to him about having eaten the tastiest burger there the last time he came, one with slabs of bacon and Swiss cheese, topped with a thick slice of grilled pineapple. Did Stephen know the burger? That would be the Hawaiian burger, Stephen said, smoothing out the ends of his stash. His silvery voice and appearance, kempt, like a man rising from a barber's chair, helped to soften the bad news that the chain hadn't carried the burger for years. Man, the guest lamented. Most general managers would have chalked up the disappointment to part of the job. Specialty burgers came and they went. Stephen, however, was not most managers. Would you like one, he asked. That would be awesome. Stephen warned him it might take a minute since he knew the kitchen didn't stock pineapple. He picked up the keys to his truck, exited the restaurant, and drove 3 miles to the nearest grocery store where, for 89 cents, he purchased a can of the prized fruit. Not 10 minutes later, the first dribbles of nectar sizzled on the grill. Stephen made sure the char was just right before flipping the pineapple over and then crowning his concoction. As the guest bit into his Hawaiian burger, Stephen knew he'd earned a customer for life. So that's Stephen. He is not the person that you might think of who has ice beneath his feet when it comes to his health care. He works as a manager at a restaurant chain, earns $80,000 a year, but as we're about to find out, he doesn't realize that he has a layer of ice beneath his feet. The burger chain offered different grades of health insurance, from Cadillac plans to the bare bones. Ever a bargain hunter, Stephen opted for the cheapest health insurance available, which deducted only $88 from his check every other week. Like buying cheese at the right price point, this was a value-based decision. In his 55 years of living on God's green earth, he had never needed to see a doctor. Why waste the money? Then in late March 2020, as the world awakened to the fact that a pandemic was spreading to all its far corners, Stephen phoned corporate with some bad news. After shaking all night with chills, he checked his temperature. Stephen was running a fever. As the only one with keys to a restaurant trying to make do during a COVID lockdown, Stephen knew this presented a problem. He agreed to open the restaurant and return home immediately for a 2-week quarantine. This would be the last time he set foot in the restaurant as its general manager. His insurance plan only provided coverage for a teledoc visit. Via his webcam, Stephen tried to show this new doctor a lymph node below his left jaw, one that had grown in size over the past year. But Zoom made it hard. The doctor prescribed him an antibiotic, and within a couple of days, what had felt like a pea beneath his skin now felt like a baseball. Stephen was sure he didn't have COVID, and he began to worry the mask was causing the fever. Aware it would cost him, Stephen decided to bite the bullet and visit the emergency room of a reputable nearby hospital. Before even sitting down in the waiting area, he paid the $639 requested, insisted upon by the hospital's clerk. This got him in the door. Next, a doctor examined him, ordered a CAT scan of his neck, and not long afterward, relayed the results. First, that Stephen had cancer in his tonsils, and second, that an ear, nose, throat doctor, or ENT, awaited him at a different branch across town. Stephen feared what the ambulance ride might cost. I feel okay, he said. I can walk. Can't I just drive myself or go tomorrow? The hospital followed a specific protocol in these situations, the ER doctor explained. Stephen walked into the ambulance and sat quietly the entire ride to the branch. Once they arrived, nobody there seemed to know anything about his situation, so Stephen waited patiently for the ENT who was supposedly there waiting for him. Finally, after many hours, the doctor saw him. He'd seen the scans and, yes, there appeared to be cancer in his tonsils. Stephen expected more after this, for the ENT to say, and so, or based on this, or to dive into some plan of action. This was cancer, after all. But the operative word was, however. However, you don't have insurance, he said. He meant sufficient insurance. It is a fiction in America that the thin plastic card bearing our name and plan is our panacea. Politicians and journalists pretend it's a tidy little equation. If you're insured, you're okay. The truth is much more complicated. Even though Stephen had insurance, it covered so little that he had to prepay the ER for a cancer diagnosis. He could live with being on the wrong end of a bad deal, for now anyway. What he couldn't quite digest was how the people in the ER had treated him. He felt shitty. It seemed wrong that they'd sent him here and there and then kicked him to the curb. He could understand that nothing would take the cancer away today and that his life wasn't immediately in danger. But how could anyone be so callous? Who says, however, in a situation like this? After the ENT departed, a social worker entered his ER room and gave Stephen some quick and simple advice. Go to the public hospital, she said. Go to Ben Taub. Stephen patted the tiny handlebar ends of his mustache. His fingers drifted to the left side of his neck, which felt hard and unshaven. In his mind, these two words, public and hospital, never belonged together. Wasn't this America? He'd never spent a night in a hospital, and now he would have to step foot in a place he recognized from the 10 o'clock news, where gunshot victims recuperated and Houston's homeless took shelter. He imagined drug addicts lining the halls, the dregs of society. This is going to be hell, he thought. I have hit bottom. That's Stephen's introduction to how American healthcare is organized. Very, 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 very different than my introduction. I grew up in, like I said, Houston, and my father was a doctor, and the contrast is pretty striking. And I'm just going to share with you how my introduction to healthcare was like. When I started working at Ben Taub, I didn't know what it meant that most of our patients had no health insurance. Growing up, I experienced healthcare the way most people in this country do, which is through private insurance. My pediatricians encountered no snags as they kept me on the vaccine schedule and ensured I didn't fall too far off the growth curve. The doctor-patient relationship looked idyllic from my vantage point. My dad delivered babies for a living, and every Saturday morning he brought me to the hospital for his rounds. I was my most docile self during our short car rides, which ended in the parking garage. From there, it was a couple of quick turns into back entrances and service elevators before we were on the labor and delivery floor. This is my son, he'd tell the L&D nurses. Yes, we've met, they would respond graciously. After the intros, my dad would punch a couple of numbers into an electronic keypad to open a door down the hall. And for the rest of the morning, I parked myself in front of the television in the doctor's lounge, where I watched TV while he visited his patients inside the hospital. It was glorious. Being at the hospital made me feel fortunate, like my dad's assistant. Aesthetically, the lounge could have used a little love. Every table or countertop had granules of sugar speckled over it, and, of course, the heavy aroma of burned coffee hung in the air. I spent hours in there. Sometimes his doctor friends would come in, sit down, and make me chat to them about my family or at school. Other times they'd see me presiding over the TV and leave as quickly as they came in. These Saturdays with my father started in America's heartland, Wichita, Kansas, where my dad worked for a private clinic owned by a group of doctors. The clinic used the hospital we visited for all its deliveries, which was how my dad had his special standing. Having joined the group fresh out of his residency and less than 5 years after immigrating from El Salvador, he worked overtime the way a young lawyer working their way up in a firm might. The established partners gave him a base salary plus incentives for productivity. His schedule included plenty of overnight calls and undesirable shifts, though my dad never complained much. It must have helped that he was young, but my dad also saw his work as a doctor as more than just a job. Medicine was his calling. Those scrubs in the OR and that suit in his clinic were his identity. To my dad, the privilege of talking with people about their problems and thinking about and sometimes operating on them was priceless. The partners set all the rules for the patients he saw and the payments he received. My dad didn't have to do anything but work. Estoy de turno, I'm on call, became a common refrain around the house. And so I fell in love with medicine through my dad's eyes. But that was in the mid-1980s, and it turns out that that's a very, very important time because medicine was actually changing at that time. When I started off with, when my dad started his private practice in Houston in the mid-1980s, he started the practice with 3 people in his office. Him, somebody at the front, a receptionist, and a nurse. But by the time I was applying for medical school in the late 1990s, he had many people working in his office, but there were 3 people full-time who worked just processing insurance claims. Now, I mean, one of those people he employed happened to be his mother, my grandmother, who is a Chicago-born, Depression-era raised woman, kind of the best person in the world to have on insurance companies, you know, because she would never relent. But he used to have, when I remember when I was initially drawn to medicine early, he would have a ritual for new patients where if somebody came to the office, he'd escort them to a room with a desk, and they'd have a conversation to start off with. But by the time that I was actually applying for medical school, that desk was completely covered with manila envelopes, like stacks of them, and stacks on the carpet, so that the cleaning crew you could see like the trails of vacuum around because those manila envelopes never moved. And so I became very disenchanted with medicine. I became very disenchanted with the idea of going into something transactional, even though there was part of me that was guided into this profession that saw some of that beauty, and then I felt a conflict with it because it looked so transactional. My father would come home and talk about just how administrative burden and the insurance companies and how he didn't have joy in medicine anymore. But what changed for me was a couple of things. Number one, in college I was an English major instead of a bio major, and reading a lot of different novels, it made me feel like I could experience different lives through books. I also started to be a doctor, or started to get my medical education was at the public hospital, Ben Taub, where all of a sudden I was exposed to stories of people. My English major, which I thought was kind of meaningless for a long time, all of a sudden my history-taking skills in medicine, I could listen to people. I could get to the diagnosis a little bit faster because of like very important pieces of the history. I could write that history a bit better. I could communicate with my team. And so the English, my love of English and my love of literature really came together also with an institution, a place, the public hospital, that was going to give healthcare to everybody no matter what, where we did not have the transactional part of medicine. It was a public institution that, I didn't realize this at the time, but was funded by taxpayers paying property taxes. So that if you earned a certain amount, you didn't have to worry about your healthcare. It was paid for by the county. And it was quite good. And those two things really alerted me to, wow, this is the field for me. The tension between what is public and what is private is fundamental to the hospital. We arrive at our weakest and most vulnerable. We present ourselves before authority figures clad in scrubs and give our arm for a vital sign check, our tongue to see if we have a fever, our insurance card if we're lucky enough to have one. We give our words, the histories of our health, our rendition of the events that brought us there. And then we wait. We wait among others. We absorb things from these strangers, not their contagion, but their body's instrumentation of it. We hear wheezes, dry heaves, muffled sobs. We see yellow skin and black bruises and the spectacle of human organs in conflict with themselves. We smell the dehydration of others, the sweet ketones in their breath, their sweat and bile. And still, we wait. From now until we are discharged, we are the hospital's wards. When finally it's our turn, we find ourselves led to a stretcher cordoned off by a sliding glass door, a wraparound curtain, perhaps even drywall and a door. We think we're better off like this. We believe this privacy constitutes more personal care, and we certainly pay more for it. But are we really better off? We are no longer with so many strangers, but we are no longer in view of the nurses and doctors either. How much privacy is appropriate in hospitals? Over the last 100 years, the architecture of emergency rooms and medical wards has changed to make care more private. Originally, 100% of hospital beds were laid out in large wards where patients lay side by side. But by 1910, that number had dwindled to 28%. As the care of the wealthy migrated from their homes to private rooms in hospitals, the large communal wards began to disappear. Then that's one thing that I had to reckon with, that even though I loved medicine, I started to love medicine again at the public hospital because of the equity that we provided patients, because it was about medicine and not transactions. It looked different than the other places. It looked different than the hospitals I'd visited with my father. These were wards. These were wards where like you would talk with a patient, you would have to squeeze in between rails in order to get histories. And so, and the thought was amongst peers, people, is that that's not really good medicine, right? How can that be good medicine if people are so crowded together like that, if there's not privacy? And that's something that I had to reckon with. But I do think that there are certain things that we have forgotten in going back to the first graph. We have a very expensive healthcare system that's really based on privacy. It's really like one of those things is like trying to provide more and more privacy at increased costs. But one of the things that I found also in working at a public system is that there are some benefits from less privacy. There's a balance to be struck, of course, but there's some benefits, and there are some things that we can glean from that. I must acknowledge that my position on the open ward was a privileged one. This is true of all caretakers. Ben Taub's open ward allowed me to stand back and observe all of my patients' activities as if they were a TV show. I had only a small protected role to play in the drama that unfolded in the Nightingale ward. If I were the one lying on the stretcher, connected to electrodes, waiting for CAT scan results, I have no clue how I'd handle myself amid the shouting, the retching, and the flashes of nudity. On one hand, I suspect I'd want to make sure the medical staff had the best chance of assessing me. In that case, I might wait patiently in an open ward. On the other, I would probably want privacy if my illness made me feel vulnerable. Some of my patients have told me that their time waiting in the Nightingale ward changed their lives. God wanted me to see it, one patient said to me. She described herself as middle class and lived in a wealthy suburb named Sugarland. She'd never thought she'd come to Ben Taub as she'd had health insurance most of her life. But a divorce left her uncovered, and that was exactly when she got sick. All of her friends told her to come to Ben Taub. She waited in the ER for hours, desperate to figure out why she was losing weight and feeling tired. As she waited, the drama of other lives unfolded in front of her. She saw prisoners and people in the throes of psychoses, all from different social classes, trying to cope with their own problems. And she found it transformative. Seeing that pushed me out of my bubble, she said. Bubble, I thought when she said this. The word reminded me of a quote from philosopher John Stuart Mill. One of the effects of civilization, not to say one of the ingredients of it, is that the spectacle and even the very idea of pain is more and more kept out of the sight of those classes who enjoy in their fullness the benefits of civilization. Patients tell me they commiserate in the Nightingale ward, that they build solidarity. Sometimes the best kind of healing happens there. Another patient told me she never wanted to wait the way she did in the holding area again. The only saving moment, she told me, was her conversation with the man next to her. He was recovering from a crack binge. He was sobbing at the state of everything, how his life was in ruins. The woman was a recovering crack addict and had been totally drug-free for going on 10 years. She told me she sang a hymn with the man, tongue-lashed him a bit. You're the only one that could stop. Told him exactly what she'd done to quit and prayed with him. Without a doubt, none of us working at Ben Taub that day had been as helpful to the man as she had been. And I think that that's one of the real lessons that I feel fortunate to have experienced and learned is like the value of community in healthcare and how one of the reasons that initial graph is what it is because healthcare has divided our community. We all have different insurance plans that are according to our work or to our or a very, very specific, class in life. It's whittled down to us, and we're trying to decide, how much we're trying to hedge. How much are we going to be spending in healthcare? How much coverage do we want? But I think that one of the lessons is that we gain a lot from community, and the way that a public healthcare system provides that is through looking at everybody and trying to address the needs and trying to take advantage of the people who are able to provide that care in the community. Now, I'm going to finish with one last person that is also an inspiration to me, and that is Dr. Anton Chekhov. And I'm going to read just a real quick section about him, and then we'll be done. There ought to be a man with a hammer behind the door of every happy man, Anton Chekhov wrote, to remind him by his constant knocks that there are unhappy people. Many people know Chekhov worked as a doctor, even as he wrote his short stories and plays in late 19th century Russia, but his devotion to the poor is not so well recognized. Chekhov traveled via horse-drawn carriage from Moscow, which sits on Israel's longitude, 3 months through the Russian tundra, nearly 4,000 miles to Sakhalin Island, just north of Japan. He did this to write about the deplorable conditions of a penal colony on Sakhalin, as well as the public health failures. More than anything, however, Chekhov wrote about the people living in these desperate conditions. As famous as he was, Chekhov could have worked as a concierge doctor and catered to Moscow's elite. Instead, he wrote stories about the poor so that the fortunate might understand that their plight is everyone's responsibility. Apparently, a happy man only feels so because the unhappy bear their burden in silence, he wrote. Chekhov eventually died of tuberculosis, an illness he contracted from the patients he served. He had been born poor. His patients were poor. He had traveled to the poorest part of Russia. He saw in his practice how tuberculosis devastated his fellow Russians with a mortality rate of 400 deaths per 100,000 people, 1.5 times that of COVID-19 in the United States more than a century later. Chekhov also recognized how little the government of his beloved Russia cared about tuberculosis and poverty. The authorities had enacted a campaign they called the Fight Against Tuberculosis, which consisted of nothing more than epidemiological studies. For all its pomp, the program received no funding from the state. Rather, it relied on charity. This touched a nerve with Chekhov, and 3 months after returning from Sakhalin, he wrote a letter to the vice director of the Ministry of Justice, a man who taught law, served as a judge, and, it so happened, had a soft spot for writers. I believe it is very harmful to have to depend mainly on charity, he wrote. I think it would be better if this problem were to be addressed by funding from the state. Chekhov explained that the problems in Sakhalin went deeper than whatever numbers might appear on a survey. I encountered no infectious diseases on Sakhalin and found very little congenital syphilis. But I did see children who were blind, dirty, and covered in sores, all diseases that bear witness to neglect. Years later, at the height of his popularity, Chekhov sat down in the dining room of the Hermitage restaurant, one of the most exclusive locations in all of Russia. As the meal began, blood began to stream from his mouth. The tuberculosis, which up to that point had for him been more of an annoyance than a debilitating illness, had caused his lungs to hemorrhage. He lay in bed for days recovering, first at a clinic and then at a hotel. The clinician and master of the written word received what treatments were available, including ventilated air spiked with turpentine and eucalyptus, wine from Hungary, a cognac after dinner. He wrote more letters in his convalescence, including to young authors, giving them advice. Your task is to be a sincere artist, writing only about what exists or what you think ought to exist, he wrote, painting pictures of life as it is. And I just want to end with that we ought to be doing what ought to exist. What we ought to be thinking about is just as de Hartog believed, what ought to exist in Houston is a public healthcare system that can bring the humanities, bring together with public service. That's the same thing that we ought to do, and we ought to keep that vision for ourselves. So thank you very much for your attention. I appreciate it very much.
Thank you so much to Dr. Ricardo Nuila. We have some time for questions. If you have a question, could you please raise your hand?
So Ricardo,
Yes.
what can we do about it?
Yes, what could we do about it is the lesson that I take from from the story in Houston is local makes a big difference. And what we can do about it is to ask about, like the way that this was passed in Houston was through a referendum, which is a democratic tool that we haven't used at the federal level. But I think that if we start locally, we can start using referendums to build for certain support for public institutions. We can also affect the way that the working federal institutions like FQHCs, federally qualified health centers, right now they're being told to restrict the care. We need to we can start providing alternate funding through the local level for those. I think that's, we're at a time right now where there's wild swings at the federal level. So I think that the lesson that history provides in Houston is that the politics at the local level really can make a huge difference in planting the seed for this.
There's a lot of unionizing happening in Boston at the level of doctors in particular, which is particularly new.
Yeah.
And I am really curious what you think about that.
That's a really good question. So I will tell you this, that I come from Texas, and the nurses don't unionize in Texas very much. And I'm interested in why the unionization is happening. I can tell you from my perspective, my experience in medicine was that it just didn't even, I didn't feel that the temporary conditions of residency and everything really were at that moment. I didn't feel the need to like unionize and to make a statement, because I felt like the program that I worked in was actually thoughtful about work hours and things like that. I do understand that that's probably that people have different experiences, but I feel like it's also very difficult, because what you're withholding is something that people really need, And like, the labor that is done is something that can have downstream effects if it's not given. So I mean, that's a topic that is I read about it, and it's hard for me to because my experience was so different, that I need to hear more about why doctors are actually bonding together and unionizing.
I wanted to ask, how did you learn to build trust with and connect with patients whose lives potentially looked very different from your own?
I think that the way I connect is through a variety of like learning and experience. I think that I was lucky enough to have certain experiences in high school and with my family. My family is Salvadoran immigrants, and we would go to El Salvador during summer, and we had a very kind of varied family in different kind of different walks of life. And I also had experiences to do kind of like public health projects when I was younger in high school and in college, that helped me connect with different people. And you just once you start kind of bonding with somebody that's completely out of your sphere, you just say, well, those spheres probably exist in all these different places. Maybe it's my own mind that's putting these kind of bubbles on people, But I also think that it's just been so much of like that's what I look to for literature. That's the tool that it gives me, is that I really do think that like great writing gives me insights into different worlds. It gives me the workings of people's brain and how they look at the world. And so reading and going through, studying the humanities has really helped. Both of those together have really helped me think about people at a level that is just like, in my mind, when I approach a patient, I'm like, let's strip away all the differences and let's see how we're really how we're really, really alike, because that helps you and that helps me. And that is something that is very satisfying at the bedside, I feel like.
I have a question about the students you teach. How many of them are interested in going to public hospitals or staying in a public sphere or public health after they graduate from medical school?
It's a great question, and I think it's so. I think a lot of the students. So I teach at Baylor College of Medicine, which is the institution that provides the doctors that staffs Taub Hospital. So a lot of the students have that experience there, and I think a lot of them do want to stay. I think I can speak from my story is not uncommon. That the reason I've stayed where I'm at is because of the public hospital. Like, I've stayed in Houston. I've stayed living in Houston. I've stayed because I really like my work at the public hospital. And what I explain in the book is that it's not so simple as like I'm a bleeding heart. That's not what it is. It's that, because I've had other situations where I've either volunteered or worked at places and I'm like, I can't do this for that much long. It's this kind of like cross-section of there's enough available to us, but it's not there's enough that we can also use our own faculties to feel like we are actually improving people's lives. And so I think it's a very common thing for people to start at this medical school and to just really stay. We have, like, every year there's students who just make it a point to stay or to go to a similar hospital. So I think it's quite, and I think it's gotten even more and more.
If you're not a particularly prominent person, what would you say is the pathway to these local activism that will foster referendums and things like that? What's the actual mechanism of making things come about?
I think bringing it up, like, I mean, I've spoken with the different political groups at the local level in Houston, and there's time where you bring it up on the agenda. You know,
what's the nature of the political groups in particular in Houston?
Well, like, I was invited to talk to the Democrats for a certain congressional district, and there's like a monthly meeting, and you can have an item on the agenda. And I think that healthcare is just one of those items that will always have some sort of attention. And that's a time where you can bring up different ideas. You know, I totally recognize that in Massachusetts, the pathway has been a bit different. It's been very much state-driven and everything, and it has accomplished quite a bit. So different states might have, and different localities might have, but I do think that there's still gaps everywhere. And I think that a lot of what needs to be discussed at those are like fresh ideas on how to do things, and what's happening in other places where they're solving some of these problems.
Sorry, we have to end there. Please join me once more in thanking Dr. Ricardo Nuila.
Thank you, Arlen.